exciting agenda today for the ePrescribing Masterclass, and it'll be hosted alongside Emma Kirk, who is the MSO Network Lead. Now, just a few housekeepings for those of you that are new to the Masterclass. Please use the questions tab, which is in the sort of icons to the right-hand side of your screen, to help post any questions that you have for our speakers today. You will get a certificate at the end of the webinar, which will be emailed to you after the session, and you'll have access to the recording as well on the NHS Futures platform. As you can see on screen, we've got 3 speakers today, and I will hand over to Emma now to start and welcome our first speaker. Over to you, Emma.
Thanks so much, Amna. And thank you for inviting us to share your webinar again this year. I know it's one of the highlights of the MSO calendar for our members, so we can jointly see what great safety work is being done. So thank you for inviting us. I've got 3 MSOs on the call who are going to share some work with us. So the first one is Anita. She's an experienced MSO from Colesdale and Huddersfield, who's going to stop contacting me, I think, as each time it ends up with a request to present somewhere. But that just illustrates how active she is as an MSO and all the work she does to improve the safe use of medicines for her patients. So today she's going to share with us her organisation's journey with electronic prescribing of warfarin, including an unintended consequence that sadly led to the death of a patient and the changes they've made as a result. Her colleagues Wendy, who's a consultant pharmacist for anticoagulation and thrombosis, and Alea, EPR lead pharmacist, are on the call too. So I'm going to hand you over to Anita now. Thanks, Anita.
Hi everyone, yeah, I've brought a team with me because I won't be able to answer all your technical questions. So next slide, please. So I suppose really it's to give you our journey that we've made, bit of background to where we started, what we did with EPR, really what some of the challenges we faced with warfarin prescribing, and really sort of use the patient's story to show what unintended consequences we sometimes can have. Really what we've done and where we are in our journey, because it's not at the end yet probably. Next slide please. So a bit like everybody, if you're using paper, you would probably have had a prescription like this. We had it bright pink, so it stood out, had all the relevant information in terms of the do's and don'ts, and really guide prescribers in how we safely started somebody and then manipulated the doses as we needed to. So next slide please. So this is where we are now. So we've been live with Cerner EPR for I think since 2017, so it seems forever, and we did go big bang with the electronic system, and we had warfarin as a power plan within the Go Live system from day one. We didn't have all of our complex prescribing on EPR, but a lot of it. So we have a tab, that an alert that lets you put in all the risk factors around warfarin prescribing, and then we've got the power plan that actually allows you to prescribe and gives you links to the guidance like we would have had previously. And then we've got a tab down for whether we're initiating warfarin in a new patient or whether we're just maintaining somebody who's already taking warfarin. Next slide, please. So when we're maintaining patients, we've got really 2 options. We've got an option for a continual daily dose for somebody that's on 2 milligrams every day. We've got a functionality for that, but probably the one that we use more than anything is this prescription here, which allows us to do variable doses and actually to do short courses of doses for 3 days, and then an INR check, and then adjust according to that. Next slide, please. So what have we found from using it really from day one is it doesn't stand out in the same way that you do when you've got a pink prescription chart. So it's not quite as visible to look at and know that people are on warfarin. You don't get all of the information necessarily in the same place. So previously on paper, you had the prescription, you would have your results very visible and your INRs, and you could see trends very easily and at a glance, and that's been quite a challenge. The way we administer medicines is different as well with EPR that we're using. We use what we call an administration wizard, which is really a snapshot of the prescription chart as a whole. It just shows you what dose is actually due now. So when a nurse is giving something, they haven't quite got the same visibility of the whole prescription that they would previously have had. And I think sort of, you know, since DOAC's come out, we've probably recognised that they've grown in number and increased in usage, and the use of warfarin's gone down over time, and that definitely means that prescribers and pharmacists are probably less experienced now in how to dose warfarin, how to look and maintain patients on warfarin safely. I definitely think the electronic systems have got a lot to offer, and they're really helpful, but I think we would definitely here say that we have become very task and focused more than patient focused sometimes with the electronic system. And I alluded to that we use that once a week approach on the different days, and that has some challenges that have come with it. So it is prescribed as one dose, and on our prescription chart it means that it doesn't grey out, or didn't grey out, until a week later. So actually a prescriber coming to look at something could actually easily think, if they were just looking at the prescription chart and not looking at the detail, that the patient was still prescribed warfarin at this point in time. We didn't have any flag on the system that alerted prescribers to say that warfarin dose wasn't prescribed for that day. And we did have a placeholder that nurses could use to prompt people, but we didn't really educate nurses about using it, so we hadn't enacted it on the system. So definitely previously on paper, if the nurse saw that the patient was on warfarin but they didn't have a dose required and prescribed that day, they would prompt the doctor to come and do the prescription. And equally so, a prescriber could see that much more visibly. So that's sort of the context of what we've been working with initially with the system. So next slide, please. So this is the patient that we had. He came in with nothing related to warfarin. They had hyperkalemia, so they did have some issues in terms of renal function that would impact on warfarin. They had a clinical condition that was involved their TERS, and they were prescribed warfarin 1 milligram for 7 days, and they were prescribed it using the Monday, Tuesday, Wednesday, Thursday, Friday. After the 7 days, unfortunately, it then dropped off the prescription, and that wasn't picked up by any of the prescribing team, the pharmacy team or the nurses. And over a period of time, the patient went without warfarin and then unfortunately was diagnosed with a stroke and subsequently went on the end of life pathway and passed away. So the case was referred to the coroners, more than just for the warfarin aspect. There were other aspects of care that were called into question as well. Next slide, please. So it's a real awakening, isn't it? You just accept things as they are, and you just try and work with the system that you've got. So, you know, what did we do and what did we look at? Probably not in any particular order. We had what we call the TDM list. So we had a therapeutic drug monitoring list, a bit Liz like you prioritise things. So we prioritise these patients to see mainly antibiotics, occasionally patients on lithium, and we discussed adding them to this list of warfarin patients, and looked at the number of patients that we'd be talking about. Was that something that we could manage as a group? Didn't solve all of the problem, but it did mean that we'd got eyes on these patients on a daily basis, including at the weekends. We did have some real challenges, and definitely last year, in terms of managing that workload, because we had a vacancy rate of about 20 to 30% during that year. So some quite strained problems in keeping up with a daily check, and we'd have to be hand on heart say that sometimes we didn't manage that 100% of the time. So it wasn't a foolproof system of saying we're going to have the best practice that we got. Like us all, we looked at datexes and we looked to see if we missed something in the themes and trends that we normally would be looking for. We did find a number of incidents that were linked to prescribing and omitted doses. Nothing that had triggered as a serious, so they were all sort of green, no harm. I think we had to acknowledge that we, as a pharmacist team, when we talked about this, would be underreporting probably the number of omissions that we actually saw in terms of practice. We had this multidisciplinary approach, and we had people sat around the table looking at what we'd got, what possible solutions from a pharmacy and a nursing, from a doctor's point of view. And Ali and Wendy have been instrumental in giving it another dimension other than me as a safety officer looking at things. We have reached out to other Cerner sites. Somebody else must have a different way of doing this. Is there a better solution for us to have? Big frustration for me from the electronic point of view is I don't know how many Cerner sites there are in the country. There's going to be 3 in West Yorkshire shortly. But why do we have a system that we're all doing something so different with, and why isn't there something that's passed between us all? So that was our initial responses to things. So next slide, please. So we've got the coroner, and sort of you can read what he said there. He wanted some assurances from us about the way we were working and that we were making a difference. And I think for me, having been involved with a coroner twice in the last year, they're definitely looking to see if we are a learning organisation and if we do make changes that are to the benefit of our patients. So next slide, please. So this is where we've ended up at this moment in time. We did make revisions to the EPR system. We, with Ali's team, managed to get an alert which now informs our prescribers if we have a patient who is on warfarin and is not prescribed warfarin for that day. So there is a physical alert when anybody, a doctor or a nurse, goes into the record and opens it up. And that, for me, has been quite a big step for us in terms of our journey. So next slide, please. And I think part of that has been allowed now because we've got a placeholder on our EPR system, which allows us to trigger and check on things electronically for the system to question things more than it did before. If it doesn't put the placeholder on, we can manually do that, but I'm not aware that we've seen many problems where that's occurring at the minute. Next slide, please. So this is, I mean, the coroner was very keen to know how we were going to make sure that we'd embedded this practice across the trust, and I suppose like other people, we used a lot of the comms that go through newsletters, and we used a screensaver to get the message out, as well as the usual cascade of information. Next slide, please. We still had an unresolved issue though. We still had a prescription sheet that, for all intensive purposes, the actual prescription looked live on the system till one minute before the next dose was due. So we still had something that was, even though there was an alert firing to tell the doctor not prescribed, if they looked at it, they could equally think the system's not right. And that wasn't ideal for us. And it was while Wendy's been doing work on to do with anticoagulation and networking with other people, that we were asked a question around what others did, and we found that we could change something else. So we were able to change the 1 dose aspect into 1 day, and by doing that it meant it grayed out a day later rather than a week later. Next slide, please. So we're now in a better position. We're probably still on that journey, so we've still got a prescription that doesn't grey out immediately that you've given the dose, like you would do if it was a stat dose only, but we've got a prescription that does grey out much more quickly, so it's a better view when we're looking at it, and it's not perfect, but it's where we are now. Next slide, please. So have we had many more incidents? Well, we still get incidents reported on warfarin, but I'm pleased to say that we've had, since we've gone live with the system as we've got now, we've got no reports coming through to do with omissions in prescribing a warfarin. So I must admit it's a bit of a mixture of things that we're using, but it does seem to have made a change. Next slide, please. And that's it. So I've got 3 minutes, I think, for any other questions, which I'm happy to take, or we'll try and respond to the chat or questions later.
Thanks, Anita. That was, yeah, it was really useful to hear, and also about the learning that you took from what happened with that patient and how you were able to use the system and adapt it. There were a few, there's a few comments and questions in the chat. There's a question from Roshan, I think, and it's asking about, oh, it's gone, sorry, 1 second. Are there any reports from EPR that you would use to inform changes in practice?
Ali, do you want to answer that, or?
There is a tool within Cerner called the Clinical Pharmacist Worklist that identifies patients that are prescribed warfarin, but so that could definitely be used to kind of see what's going on with patients on warfarin, and then yeah, inform future practice.
And then you'll see, Anita, there's just some other comments that are in the chat, which you'll be able to either you, Wendy, or Alia answer. And some people have had similar experiences in terms of what they've done and maybe reverting to paper and using the system. I think there's another Cerner user talking about if it greys out, then it enables them to have some sort of handover. So the changes that you made were obviously helpful. Yeah, I think what I'll leave you to answer the questions whilst the next presenter does their presentation. Is that okay, Anita?
That's fine, thank you.
And thank you again. It's really interesting to hear that. Emma, I'll pass back to you.
Yeah, thanks, Anita. We're a Cerner site, my organisation too, and we are still on paper. So I think that's the beauty of these webinars, is that looking to see what others do and try and jump on. So thanks for sharing that. I'm going to hand over to our next speaker now, who is Jen. Jen is Associate Chief Pharmacist for Clinical Governance and the MSO at University Hospitals Birmingham. She's going to share with us how they've picked up on a theme of incidents relating to insulin dosing errors, some electronic solutions they've implemented, which some have been successful. Jen is, I know that she's keen for feedback from colleagues working in digital teams for further ideas to minimise the risk that she's going to describe for us. So if you have got any suggestions, please do put it in the chat, because I know Jen would like to get in touch about it. So thanks, Jen.
Thank you, Emma. That's brilliant. Yeah, so hi everyone, I'm Jen. Yeah, it's just to take you through a theme of errors that we've picked up over, unfortunately, the last couple of years relating to insulin prescribing. So if I could have the next slide, please. Just a little bit about us. We are a very large trust. We have 4 large hospital sites across the geography of Birmingham and Solihull and community services. And we have about 2,800 beds across all our sites and treat over 2.2 million patients per year. Next slide, please. So just to give you a bit of background, I think my colleagues have presented here before, but you'll be aware that UHB has something called PICS as their electronic healthcare record. It's an in-house developed sort of system. It covers basically everything from noting, prescribing, order communications and results reporting. It's a really comprehensive system that covers all outpatient, emergency, inpatient and yeah, all kind of care settings really. Specifically for the prescribing element, I mean, PICS is really advanced and does support structured prescribing, has chemotherapy rotas, and has really diverse clinical workflows such as scaled doses and all of those things that I list there. So we do have an in-house EPMA essentially. So that's our sort of EPMA background. If I could have the next slide, please. So yeah, so a couple of years ago, we began to pick up on an error theme that would probably send most MSOs needing to sit down, and it was that we were having insulin prescribed at the dose of 100 units instead of the patient's correct dose. Just put on this page here some examples of those incidents. So often yeah, it was picked up before it was administered, but sometimes it wasn't. For example, on that bottom left-hand corner, a patient who had 3 hypos in 24 hours. And it was a diabetes nurse who reported this incident. And when they went to attend to look at why the hypos were happening, they observed that the patient was prescribed 100 units of Lantus daily, which was the strength of the insulin, not the dose that the patient should have been on. And that was a particularly bad example for us because it was an example where we had identified the correct dose and it had been recorded, but there'd been no follow-up that the dose had then been prescribed incorrectly, and then that had been sort of carried on for a number of days. So yeah, we've had a mixture of this error occurring and being picked up before anything bad happens, but we've had some examples of it actually getting to the patient. So it was a big risk for us as an organisation. If I could have the next slide, please. Our first intervention was weak, but still necessary, was around the communication and highlighting of the risks across the trust. So we use the patient safety notice as a communication method to sort of highlight important safety issues, and it's a standard method of communication. So it is, although it is communication and not a sort of strong barrier, it is something that's recognised across the trust and is used at handovers in all areas. So it was considered necessary to do so, and that just highlighted the fact that it is possible to, you know, the concentration of the insulin is recorded often in the medication list for the patient, and so it is possible to inadvertently think that concentration is a dose, and similarly often there is no dose documented in a patient's medication record for insulin because it's so variable. It might just say as directed, and so the only number you may read as a prescriber or a clerking clinician when you are thinking about prescribing someone's insulin in the first instance may be the dose of 100. So we've just highlighted that we wanted everyone to check and recheck and think twice when they are prescribing. If I could have the next slide, please. We have the diabetes. We have a very strong diabetes team in our trust, and we have a diabetes consultant nurse, and she actually undertook specific interviews with prescribers she was able to contact about this error, and she picked up a number of kind of themes and trends that came through from these errors from those interviews. It did feature more prominently than other classes some international training fellows, so there might have been an issue around familiarity with UK insulins, but the point was made by all that they feel that they had mistaken the insulin strength in the GP record to be the dose. So this was a strong sort of underlying sort of cause that was highlighted by those involved. At this point, we had implemented a password level warning, and you know, on querying why this might be bypassed, it was just that they had based this on observing others ticking and signing them off and a degree of alert fatigue. And there was also a lack of awareness of the UHB insulin safety Moodle amongst prescribers. So we do have this e-learning package that is meant to be widely used, but I think there is some work to be done on that being promoted and accessed by prescribers. If I could have the next slide, please. So as I mentioned, one of the stronger interventions we then undertook was to put in a password override warning for doses of 100 units or more for any insulin. So as you will see here, the red writing is what appears if you try and prescribe 100 units or a higher dose than that. So it's saying basically you've prescribed a multiple of 100, check that it's the actual dose and not the concentration. And then it also says you've prescribed a dose higher than 99, please check that it's correct. And both of these need to be ticked off, and a password of the prescriber needs to be entered to move forward with the prescription. So it's a fairly strong barrier that is used in other ways in our system as well. So these were implemented fairly quickly in order to try and get a grip on this. If I could have the next slide, please. Then just coming back to the point which I feel is quite fundamental and be really interested in other people's views in this, is the presentation of the insulins in the summary care record, where a lot of people get their information about drug history and what to prescribe for the patient when they're admitted to hospital. Within our organisation, you can actually have two display views of that depending on the access route that you take to access it. So you might get a tabular view, as in the top picture there, which I think is a bit clearer than the bottom view, is that you get the kind of formulation on the left hand side, and then you get the dose in another column. But it may also be accessed, and they can see this line by line option at the bottom here, where I think it's slightly less clear. But in both cases, I think it is interesting to note that if you're reading it sort of left to right as you would, 100 is the first number you see. So you can see how perhaps this error arises, and I'm sure that it's happened in other organisations, or people will tell me that it has or hasn't. If I could have the next slide, please. So we are continuing to monitor this error. We had lots of oversight from the Trust Diabetes Steering Group and the Safe Medicines Practice Group, so we continue to monitor this. Some of the clinical fellows made sure that there was some insulin prescribing teaching slides circulated to the junior doctor workforce, and that will be periodically reissued. And there's been continued promotion of the safe use of insulin e-learning by the diabetes team. If I could have the next slide, please. And our latest intervention, which happened, I think, just before Christmas this year, was that we've developed an email alert. The PICS team developed an email alert to basically alert the pharmacy team whenever 100 units is prescribed. So the idea of this, although it doesn't obviously stop the error occurring, is that there can be an intervention before anything sort of serious happens, and that it can be reviewed. So whenever a dose of 100 units is prescribed, the pharmacy team receive an email alert. The process within pharmacy is that this is followed up at daily huddles. So there are huddles at 9 and at 2, so just twice a day by the clinical pharmacy team, and any that are picked, these are directed at each site. So we have obviously 4 sites, and so that for one site you'd only get the alerts for that site, and they would review their site's alerts and make sure that they've been followed up by a clinical pharmacist to make sure that that's intervened on if it's inappropriate. At weekends, and it would be picked up by the weekend team, and it would be a remote sort of call to the clinical area. Similarly, if it's an area that we don't visit, because I hope we're not alone in we can't visit every single area in the hospital, we just do not have the resource to do that. It would be done by the responsible pharmacist in the dispensary, because they could also access those alerts there. And this was based on a similar model that had been implemented for us around clozapine prescribing. So we get alerts when clozapine is prescribed to ensure that we can make sure that we get that supply in a timely fashion and we don't risk the patient having to retitrate. So we use that model for clozapine, and it worked really well. So we've kind of implemented that and copied that over for this to try and see if we can intervene. Obviously, it has some limitations. We are not on site. We don't expect the on-call pharmacist to monitor this and intervene. So and also it's a retrospective alert. We get the alert once it's happened, not when the prescriber's thinking about doing it. So we can only intervene after the case has occurred. Have the next slide, please. So this is just what the alert looks like. As you can see, it just gives you the details of where and who and which prescriber has done it as well, which is useful because it means you can know who to contact to try and resolve the problem. If I can have the next slide, please. So our current status, we have still continued to have alerts for occurrences of single doses of 100 units or more of insulin since January. So we've had 21 of those. Analysis ongoing of those. It can be quite difficult to unpick them sometimes, and there is within there is some correct doses, so we do need to note that, and that will come out in the chat, I'm sure, but that is something that is important to consider. Sometimes that is the right dose and we don't want to disallow it. But so far, thankfully, none have been reported as administered that we're aware of. So I would say that would demonstrate some limited success for the intervention, but from my point of view, I feel the risk is not eliminated completely, so a little bit nervous about that. And I think from my perspective, the considerations to take forward are really around the summary care record, display adaptations and what is possible there, and any stronger EPMA barriers, such as disallowing the 100 units, which so far is not something that has been supported within our trust. But I'd be interested to see what other trusts are doing around that, because I know within our region, speaking to the MSOs in the West Midlands, I know the error has occurred there, and I'm sure it's occurred more widely. So it would be great to hear your thoughts on this. And that's where we are. So I'll hand back over. Thank you very much.
Thank you, Jen. That was really interesting to hear about the issues that you had in regards to insulin. I don't think you will be alone in having that. I'm sure there's other organisations, and when you said about every ward is seen, again, I'm sure people relate to that and the limitations of where you are physically to be able to deal with those interventions. There was a question from the audience around, were the errors before or after a pharmacy medicine reconciliation was undertaken? So the prescribing errors.
It's a mix. Some of them occurred when there'd been a meds rec, and they'd recorded the correct dose. Doctor or prescriber had obviously not looked at it, but then there'd been no follow-up from us and a period of time where that hadn't been caught, and sometimes where we hadn't. So there's a mixture. In fact, I think in an audit that we did, there was an instance of where also it was misrecorded by a member of the pharmacy team as well, incorrectly. So it's not just, it can happen to anybody really. So yeah, it's a mixture. It wasn't clear that there was a particular theme.
Yeah, that's great. And there was just another question about, I think it's from the audience, about who is aware of the password when a dose higher than 99 is prescribed. Is that something that,
Sorry, say that again.
It was around the password for when a dose of higher than 99 is prescribed. I think, did you mention about the password requirement if it's going to go above that level?
So it's the user's password, so they're like login, so it's like them acknowledging it. Is that what the question means? Yeah, I
think it was the software being able to do that in terms of the prompt around. I think they're probably asking the rest of the audience to see if anyone else knew about that being a possible sort of solution. Just a question I had around, so you get the email alert when there is above like 100 units prescribed, and then is there a feedback mechanism? You talked about the prescriber, but for example, if the prescriber wasn't there because the shifts change or whatever, is there some sort of follow-up loop mechanism just for the learning element of it?
Yeah, we haven't got that nailed down, to be honest. There should be, and I think that's probably, we're kind of working on that now. We're trying to collate all these alerts that we're getting, seeing what action's been taken, looking at noting. It's quite hard with the size of the organisation to keep on top of it, to be honest, but absolutely there should be, and that's something we'll be working on.
I'm just going to ask if any of the other speakers or panelists want to ask any questions whilst we've got Jen before we move on to our next speaker with Liz.
I was just going to comment, Jen. I think we all struggle, don't we, when patients are admitted, finding out what their insulin dose is, particularly if they don't administer it themselves. And even if they do administer it themselves, I know we have an issue with, clinicians at the point where they go and prescribe the medicines, they've usually left the patient by that point. So they're not there, they haven't asked at the time, and then they don't go back. And, insulin passports are, I don't know, pretty non-existent in our area. I don't know about yours. So often you wonder whether, if the dose isn't on summary care record, which, you know, for a lot of patients is not appropriate, it changes too often. You know, I can see it is the only number there, isn't it? And it's why they take it. I was just wondering, from a insulin passport point of view, or actually finding out the dose, has your area nailed that problem?
Wouldn't say so, no. So, I wouldn't say there's ubiquitous use of insulin passports here. So yeah, I think, you know, the pharmacy team are good at asking the patient or the carer and getting in touch and specifically having that conversation. But you know, I don't think that's something that we have nailed in terms of the wider workforce, really.
Thank you, Jen.
Are we ready to move on?
Yeah, I'll hand over to you, Emma.
Well, thanks, Amna. So I'm going to introduce our last speaker, our last MSO. So Liz is the Principal Clinical Pharmacist and MSO at Northern Care Alliance, not for much longer, but she is going to share with us how NCA are using a safety dashboard to support the safer use of medicines. And I know lots of us, when we met earlier, were very excited to hear about how we can use lots of their ideas to take over to our own trusts. So thanks for sharing with us today, Liz.
Thanks, Emma. And just to as I will cover in the next slides, this is very much in the infancy, so it's a new project that we've been working on. So I don't have all the answers, but it's just a nice opportunity to share with people where we're up to and how we've got started. So first slide, please. So just to benchmark for us all, detecting medication errors. We know that using prescribing safety indicators, statements of hazardous prescribing events are available. We know that we can incorporate these into information technology through various different systems, whether they're prescribing systems, EPMAR systems, and the whole theory is that these will support health professionals to improve safety and quality. I think at this point we would all agree that there's a massive assumption in various different quarters that electronic prescribing systems have an inherent safety inbuilt that will prevent a number of errors, which they in fact don't. I think there's a lot of electronic dashboards already available, and lots of systems can help provide summary data, they can help to interpret, and they can provide actionable patient level feedback. But actually understanding how people interact with them is as important in terms of human factors from a patient safety and medication safety point of view. We're lucky in Salford in that we were involved with the SMASH, the Safe Medication Safety Dashboard intervention, which was in primary care, and that was over 10 years ago now, which used information technology to create a dashboard accompanied by long-term clinical pharmacy support to help perform a safety net function. So a lot of the project that I'm going to talk about today is built on some of that premise. We do know that increasing use of IT offers new opportunities, but we have lots of trials, lots of ideas, and actually understanding the human interaction and how this actually adapts as time goes on, what that engagement piece is between the health professionals and the technology, so that, as is happening today, which is fantastic, we have our people that focus on and understand the technology working with our clinicians in practice, and we can actually assess from a governance and managerial point of view what the potential impact is on fundamentally changing our working practice roles and responsibilities. So next slide, please. So the study that we have been talking about for a long time is called the Impact Study. The aim is to evaluate the impact of an interactive dashboard on patient safety, how it's implemented, adopted, and how it's used within a hospital in Greater Manchester, which is Salford Royal. The questions that the study are looking to ask is, what's the effect of the dashboard? What's the relationship between the usage patterns and the effect? How is it implemented, used, and embedded in practice? And how do we interact with the technology and with other users? So just a couple of questions. Basically, to do this, though, we've had to develop a dashboard of prescribing safety indicators to work alongside the clinical pharmacists. We've developed action cards to support decision making, so outside of our EPR system, which I think is key to understand. And we're about to start some formal evaluation from the University of Manchester. Next slide, please. So the indicators were taken from Pincer and local intelligence from myself as MSO, using some of our safety incidents at work, some regional MSO work, and looking at some of the 50 plus Pincer indicators, and we agreed amongst us which ones would be the local priorities. These indicators are then developed by our business intelligence team by extracting data from our electronic patient record system. We are very fortunate at Salford in that we have a fully integrated electronic patient record system with pathology test results, prescribing system, clinical notes, etc. And I think that's very relevant to this piece of work. As with all good processes, we have a validation process for both our BI and our pharmacist team using test patients, then live patients. And because of that, the indicators have been released in batches as they've been validated and able to go live. The first indicators went live, I've said over the May bank holiday, but actually we did a soft launch over the Easter bank holiday weekend before the 4-day break. And our current position as of this week is that we have 24 indicators live, but there are obviously a lot more to come. Next slide, please. So in practice, the data is extracted and interrogated using rules, algorithms and criteria. So it takes information from our prescribing, administration, clinical notes, pathology, and is absolutely independent of the EPR system. So it's a data extract that informs our dashboard, which I think is important because it should mean that it's transferable and can be rolled out to other systems. The key thing that we're most excited about is the search combinations that underpin the indicators, and I will give you some examples of these. But instead, it's not just drug-drug, it's drug and blood result, it's drug dose and body weight, past medical condition, and a really key one is absence of a drug. Next slide, please. So these are some of the examples, if I just take a couple of minutes to go through. So a single prescription where we have a patient prescribed apixaban 10 milligrams twice a day for more than 7 days, that will flag up onto our dashboard. For clozapine has been a particular problem locally, so we have an indicator for where it's being prescribed but not recorded as administered in the last 24 hours, so preventing 48-hour missed doses. We've got some traditional interactions, we have some therapeutic duplication, which we don't have within our electronic prescribing system, but we also have the ability to flag up low molecular weight heparin prescribed for a patient with low platelet counts, for example, or where a patient's got hypokalemia, hyponatremia or hypocalcemia with a thiazide. We're also using drug and patient alerts with apixaban, for example, if the dose hasn't been reduced and the patient is over 80 and the body weight's been recorded as less than 60. We're also moving towards using some patient factors such as an antipsychotic being prescribed for a patient who has dementia recorded in their clinical notes. Next slide, please. And this is what it actually looks like. I'm sorry it might not be in particularly good focus, but this is what the clinical pharmacist will be presented with as they come in the morning and log into the system. The impact indicators will show which ones are flagging. This was taken yesterday, so I don't know how good the screen is, but we had 3 patients in our 860-bedded hospital flagging for low molecular weight heparin prescribed for a patient with low platelet count. That also includes patients where the low molecular weight heparin is suspended. So we have set the indicators up to flag both for live and for suspended, depending on the indicator. We have 2 patients with apixaban dose not reduced, over 80, body weight less than 60. We have 2 for the thiazide, and we have a level 3 severity, which is our lowest priority for patients over 120 kilograms who are prescribed a DOAC. It's really important that this isn't a definite, you must go and do this. This is an indicator to flag patients up for review. The other really helpful part of the system is the assurance part. So the second part of that slide shows the number of indicators where no patients are affected on the overnight data run. So it gives me that confidence to report back at a governance level that I don't have any patients prescribed apixaban, a dose of 10 milligrams twice a day for more than 7 days currently in the organisation. The numbers on this chart relate to the indicator numbers, and the severity is where we prioritise a number 1 for immediate action within the hour, a number 2 within the day, and a number 3 green is during the patient's hospital stay. Next slide, please. Within that first page of the indicators, we can filter down to find out where the patients are. So we, as you can see from the patients that we looked at yesterday, that's the ward spread out of the 40 wards that we have where some of these patients are. And we can drill down to an individual patient level based on NHS number and name. We also have the ability to modify the actual prescription, which will pull through to the next dashboard run, which will say whether it's been reviewed, whether it's still valid, because the indicator will still flag during that patient stay for as long as that is still relevant. Next slide, please. As I mentioned before, we deliberately did a soft launch over the Easter bank holiday weekend where we didn't have a ward-based clinical pharmacy service. The agreement was that the responsible pharmacist in the morning would come and check the dashboard and find out and identify where there were any patients. We monitor our usage and the interaction on a regular basis, and you can see that we do have staff monitoring the impact dashboard at a weekend when we don't have a ward-based service, but it does give us that opportunity to make that proactive intervention. The dashboard run is in the morning, and again, the second part of that slide shows the time of day. So as people are coming in the morning, they're interacting with the dashboard. Over time, people have changed their habits. So now we have a lot more teamwork where one member of the team will log in the morning. They will identify if there are any patients flagging within their clinical team ward areas, which is a really great opportunity also for supervision and for helping and backing up our junior pharmacists to make sure that they know how to act and how to act appropriately in these with these indicators. Next slide, please. So we are currently evaluating the project, and there are a number of system developments. We are continually building new indicators, and there's definitely a momentum within the pharmacy department and beyond where people think of ideas that would be great. This would be great if we could flag this on the dashboard, if we could have this available. Our next priority is patients who have recorded type 1 diabetes, which is linked to our local piece of priority, where basal insulin isn't prescribed or hasn't been given. We do a lot of work as MSOs talking about missed doses, but if it isn't prescribed in the first place, that's an area that is quite difficult to pick out. So that's one of our next focuses with this. Next slide, please. I put a couple of email addresses. Hilary, who is our main research and clinical pharmacist lead on this, is an expert in building all things to do with the system as well. I think it's been really interesting for us just seeing how much potential there is within this system. We're already within the first weekend, we were able to pick up a patient who would have missed 48 hours of clozapine had we not been able to identify them through the system. And it's helping at weekends, bank holidays, and where, as somebody mentioned at the very beginning, we're unable to provide as full a service as we would like to. It does give us an opportunity to at least identify some aspects for intervention. Thank you.
Yes, thank you so much for taking time out and share this project with us. It's really amazing. And from the delegates, we've got some positive feedback to say, oh, it looks really nice. There were some questions with regards to the indicators. Are you able to share a list? Because I think a lot of people who join us today will be interested in that.
Yeah, I think we can. They are based on the pincer indicators, so they're based on quite a lot of published evidence within some of the previous working with based on the SMASH and pincer. So most of them are ones that we've taken from elsewhere that we've looked to see whether they were relevant for our local departments. Sometimes some of the indicators, if they require complex interaction with the EPR system, will take longer to validate. So I think there is a decision to be made as to do you go for the difficult ones with the potential highest impact, or do you go for the highest number with the quick wins? But yeah, I'm sure we can share some more of that information. I can append that to the chat.
Yeah. There was another question with regards to do you use natural language processing to get information out of the clinical notes to understand if a patient got a certain indication, or how does that work?
So I have no idea about the technicalities, but what I do know is that because we've built this very much with our BI team and with our jobbing frontline clinical pharmacists, we have done a lot of work looking at what words we use. So dementia, for example, if we use the dementia one, actually describing how would somebody record that? How would the consultants record it in the notes? How is it coded in the notes? So I think what we've tried to do is use as many synonyms and as many different words that can be pulled out of the system, and it does have the ability to do the free text search as well within the clinical notes, as well as looking at health issues and significant events. So we've tried to have as many feeds into the data pool as possible. I don't know if that helps at all, if that answers the question.
Yeah. And then one is perhaps maybe a bit about staffing. Is the dashboard only accessed by pharmacy? Because obviously the dashboard information that it pulls out could be useful for different clinical teams as a pharmacy. Is there a dashboard available for clinicians perhaps, or nursing staff?
So at the moment, because we're still rolling it out and working out how to do, it's not hidden, but it's not necessarily advertised to the clinicians. And very much, we are not a 24/7 service, so it isn't something that we should really be holding within pharmacy. However, it isn't live. It is only on at the moment. It's on a data pool at I think it's run between 4 and 6 a.m. So there's less advantage for it being publicly available immediately, because it does have that opportunity. However, the plan will be to, and one of my colleagues was speaking to our acute and complex medicine consulting governance meeting yesterday, because they are really keen to look at certain indicators. At the moment, we're running it through the pharmacy, because we can look at where do we think that highest risks are and what the priorities, as opposed to if we go out to the clinicians, each area will have their own key priority area. But absolutely, eventually, I think there should be something that's accessible for all, and we are looking to see if we can roll it out to the other sites within our trust as well that don't use the same EPR system, to see whether we can, whether we can spread it to different medication administration setups.
So the dashboard, is that compatible with the different EPR systems then? Because there was a question in the chat to say, what system do you use?
Yeah, so we use, it's all scripts that we use at the moment, but it absolutely is standalone, and that's the whole design of it, that it's a data extract that goes into the algorithms to then set up a BI Power Apps dashboard. So it very much sits outside of the EPR system, and it's not dependent on the functionality of the EPR system, as long as the information can be pulled out from it.
That's amazing. And you mentioned something about that you've gone live with, you said 24 indicators. What's the rollout plan look like for the remaining ones that haven't gone live yet?
Well, as everything, it's all in the queue within the BI resources, which is why we have prioritisation meetings once or twice a week to actually look at where we want to go. And at the moment, we've agreed that we think the insulin one should be where we focus our attention, because it's an ongoing issue that I don't think anybody's managed to successfully fix, in terms of how do we get patients prescribed something, and how do we know that they should be prescribed until afterwards. So that's our priority, to try and get that one up and running. The next one after that, we're looking at patients who got potassium supplements prescribed and haven't had a potassium level check, or that their levels are too high. So we're looking at those interactions between the pathology system and the prescribing system as being the next stage. And we're hoping to release another batch of 5 to 10 over the next few weeks.
It'll be interesting to learn more about that and the rollout.
I'm sure we'll come back next year and let you know where we're up to. But I say it's an opportunity really to share with people where we're at this initial stage, and as we learn more about how people interact with it, that's also really important learning for future developments.
Amazing, Liz. Thank you so much for your time today. For the interest of time, are you happy to take on some of the questions offline? Yep, amazing. Amna, I think I'm handing over to you.
Yeah, no, thank you, Hoyan. I just want to thank again Emma and all the speakers that have presented today for putting together such an interesting and thought-provoking discussion. We've seen from Anita and how they learned from the warfarin incident, and using the digital system to overcome that, to prevent something like that from happening again. And then Jen spoke to us about the insulin and the problems of prescribing, and looking at how these small interventions can actually try and negate some of the risks, but obviously there is still work to be done. And finally, Liz sharing the dashboard and how that can be used in prioritising patients. So it's been really transformative in understanding, what's out there, and should hopefully give you all something that you can take back and look at in terms of your own organisational systems. Emma, would you like to add anything before we close?
No, just thank you, for letting us join you today, and for the MSOs for sharing their work. And I think this just shows us that it's a key relationship between EPMA colleagues and MSO. We are all striving to make medicine safer for our patients. So, just thank you for letting us join you, and we all just need to keep fostering these relationships, because we need each other to do our jobs. So yeah, thanks for having us.
No, thank you so much, and we will have you back on again next year, again to showcase this work, hopefully earlier in the calendar, so that you can come back and bring all of the work that's been going on, because like you said, it is a collaboration and it is needed. On the screen now, everyone, you'll see there's a QR code for our next masterclass, which is on the 18th of September. There's a break over the summer period, so please do scan that and register for the September masterclass. If you also have any ideas for future topics, or we always look for speakers or volunteers to present any of the work that you've been doing in your organisations, then please do email Sarah from the Health Innovation Network, and we hope to see you all in September again. Thank you for joining us today. Have a great day.